Welcome to QMP's e-learning course, Surgical Correction of Alopecia in the Male Patient. Our instructor is Alfonso Barrera, MD, a noted expert on this topic. This interactive tutorial provides the fundamental knowledge and step-by-step technique needed to perform hair transplantation with the micrograft and mini-graft procedures. Our goal is to provide you with a learning experience that is both enjoyable and educational. Course format. This dynamic tutorial has the following format. 1. Introduction. 2. Course objectives. 3. Overview. 4. Indications. 5. Anatomy. 6. Preoperative planning. 7. Technique. 8. Postoperative care. 9. Problems and complications. 10. Results. The total time you need to complete the course is approximately 60 minutes. After completing this learning session, you should be able to describe indications for hair transplantation, identify pertinent anatomy, discuss the operative approach and marking technique, outline the steps of the micrograft and mini-graft procedures, describe possible complications and problems and ways to prevent them, discuss postoperative care. Hair is an important visual component of facial aesthetics. The hairline frames the face and defines the proportions of its upper third. A full head of hair with a properly positioned frontal hairline conveys an appearance of vitality and youth in men and women. Conversely, an absent, eroded, or disproportionately high hairline results in an aged appearance. The most common types of hair loss include male pattern baldness, female androgenic alopecia, post-surgical alopecia, post-traumatic alopecia, and congenital hair loss. Male pattern baldness is the most common type of hair loss. The genetic information for hair growth is located at the hair follicle level. Men who carry the gene for male pattern baldness will end up with a variety of hair loss patterns, including hair loss only at the front hairline, hair loss only at the crown, or hair loss across the entire top of the head. The balding areas have different genetic programming than areas of the scalp that do not lose hair. Male pattern baldness usually occurs primarily on the top of the head, and not in the occipital or temporal areas. The hair follicles on the top of the head are genetically sensitive to dihydrotestosterone, DHT, and those in the occipital and temporal areas are not. Androgenic alopecia in females is the second most common type of hair loss. The loss of sideburns and frontal, temporal, and/or retroauricular hair loss are common occurrences after facial rejuvenation. Alopecia may also occur after oncologic resection of the scalp or eyebrows. Examples of post-traumatic alopecia include hair loss caused by injuries such as burns, traumatic injuries of the scalp and eyebrows, and scalp avulsions. Examples of congenital hair loss include the absence of mustache hair in cases of bilateral cleft lip, triangular temporal alopecia, and nevus sebaceous of Jadison. Causes of male pattern baldness. Male pattern baldness is a hereditary condition that appears to be controlled by a single dominant sex-linked autosomal gene. The initial signs of thinning hair clearly correlate with puberty in males. In this stage of development, testosterone levels start to rise, which gradually converts terminal hair into vellus hair. Initially, this results in a receding hairline. Depending on the individual's inherited genetic features, the hair loss may progress until only a temporal and occipital fringe remains. The long-term viability and continued growth of transplanted hair is dependent on the genetic programming of the hair follicles from the occipital donor area. This concept is the basis for success in hair transplantation. In other words, transplanted hair will continue to grow in the transplanted site in the same growth pattern that it had in the donor area. With the current technique, natural, consistent, aesthetically pleasing results can be achieved with 1 to 2 hair follicular unit grafts, micrografts, and 3 to 4 hair follicular unit grafts, mini grafts. For patients with male pattern baldness, between 1,000 and 2,500 grafts are typically placed per session, depending on the degree of hair loss. Indications. To date, we have no method for creating new hair. All current techniques for hair restoration involve redistributing the patient's existing hair. Good candidates for hair transplantation are those individuals who have a favorable donor site surface area and density relative to the size of the area to be transplanted. The better candidates for this procedure are patients who have denser and larger donor hair follicles at the occipital and temporal areas and proportionally smaller bald areas. The ideal candidate for surgical hair restoration has a stabilized pattern of hair loss and a sufficiently large donor area. In these individuals, 1,500 to 2,500 mini grafts and micrografts can be planned for maximum hair density. The hair dermal papilla, the fibrous sheath of the follicle, the blood vessels, and the erector pili muscle originate from the mesoderm. The hair matrix and the melanocytes are of ectodermal origin. The melanocytes produce color granules in the central hollow core of the hair shaft, thus giving hair its natural color. The cells from the matrix divide and are pushed upward. They are continuously replaced by new cells forming beneath them. Later, special cells form two buds that develop into the sebaceous gland and erector pili muscle. The matrix cells continue to be pushed up and outward, and they become dehydrated by an extrusion process, which forms a tubular hair shaft of dead protein called keratin. This hollow tube is then filled with melanin. As we age, the melanocytes cease functioning, resulting in gray or white hair. Transverse histologic sections demonstrate that hair follicles grow in follicular units. Maintaining these intact units appears to increase the survival and ultimate hair growth of the grafts. Optimal graft survival and ultimate hair growth depend on transplanting more than just the bare hair shafts. Slightly chubby grafts and intact follicular unit grafts thrive much better than bare hair shafts. Growth cycle of hair. The life cycle of a hair follicle includes the following phases. Anagen is the phase of active growth, when the follicular cells multiply and keratinize. On a non-balding scalp, normally about 90% of the hairs are in this phase, which lasts about 3 years. During the catagen phase, the base of the hair becomes keratinized, forms a club, and separates itself from the dermal papilla. It then moves toward the surface, eventually connecting to the dermal papilla by a connective tissue strand. This phase lasts 2 to 3 weeks. During the telogen, or resting phase, the attachment at the base of the follicle becomes weaker until the hair sheds. The follicle is inactive and hair growth ceases. This phase lasts 3 to 4 months and commonly occurs after hair transplantation. However, even hairs in the telogen phase ultimately grow when transplanted. It is important to explain the growth cycle of hair to a patient before the hair transplantation procedure is performed, because the catagen and telogen phases will occur postoperatively. It is common to have no visible improvement in hair density for the first 3 to 4 months after hair transplantation. In fact, the hair may look thinner and less dense than it did before the procedure. The transplanted hair will continue to grow for about 2 weeks postoperatively. After this initial growth, a large percentage of both transplanted and native hair will shed temporarily. This is called telogen effluvium. Next, the hair enters the telogen phase, which is triggered by the trauma of the hair transplant, specifically the incisions made on the scalp. This phase may also be caused by the temporary loss of a blood supply to the transplanted hair follicles during surgery. The anagen phase begins 3 months later with the emergence of fine vellus hair that will gradually thicken into terminal hair. Even though the increased hair density is visible, actual hair growth does not occur until 5 to 6 months postoperatively, with the final result being evident at 10 to 12 months. In females, the final result may take a little longer. Types of male pattern baldness. Type 1. There is minimal or no anterior hairline recession at the frontotemporal areas. Type 2. Triangular symmetric frontotemporal recessions extend posteriorly no more than 2 cm anterior to the coronal plane drawn between the external auditory canals. Type 3. The frontotemporal recessions extend posteriorly beyond 2 cm anterior to the coronal line drawn between the external auditory canals. Type 3. Vertex. Primarily a vertex hair loss, but may be accompanied by a frontotemporal recession that does not exceed that described for Type 3. Type 4. The frontotemporal recession is more severe than in Type 3. There is sparse or absent hair in the vertex area, but both areas are separated by a band of moderately dense hair that goes across the top of the head. Type 5. Hair loss in both the frontotemporal and vertex areas is more extensive and only separated by a narrower and sparser band of hair across the top. Type 6. The band of hair separating the frontotemporal area and vertex is gone. The two areas are interconnected. The entire area has extended laterally and posteriorly. Type 7. The most severe form of male pattern baldness with only a narrow horseshoe-shaped band of sparse hair. Preoperative planning. Careful preoperative planning and effective patient instructions are crucial for achieving successful results with micrograft and mini-graft procedures for hair restoration. Male pattern baldness is a progressive condition. The rate of hair loss may slow down after the age of 40, but it never stops completely. Therefore, the preoperative plan must ensure natural results for both the short term and the long term. To obtain a surgical result that mimics nature, a large number of randomly transplanted small grafts is key. This provides a result unmatched by any other method of hair restoration. Good communication with patients is essential to establish realistic expectations. Patients must be forewarned that 2 or 3 sessions may be necessary to obtain the desired density, assuming there is sufficient donor hair. Often, however, significant improvement is seen after just 1 session and will persist for years even without a repeat procedure.
Seriously considering to incorporate hair transplantation into your practice, I recommend that you visit a surgeon who's actively doing this and spend a couple of days to see the ins and outs of the procedure, include your assistants. They also need to become familiar with how to do this. Whenever you do a coronal forehead lift or any procedure where you have some scalp to be discarded, perhaps from a facelift even, save the pieces of scalp, take them to your office, and on those pieces you can practice yourself how to make the 2mm thick slices, and also gives a chance to your assistants to practice on the graft dissection. The graft had to be dissected gently and atraumatically for them to allow for growth after transplantation.
Patient preoperative instructions. The patient is given preoperative instructions as well as informed consent paperwork to review and sign. It includes the following directives. Do not take aspirin, ibuprofen, or antihistamine allergy medications for 10 days before surgery. Wear comfortable old clothes because they may become soiled during surgery. Make arrangements for transportation to and from surgery. On the day before and on the day of surgery, wash hair with a mild shampoo, such as Neutrogena, Progain, or Johnson & Johnson baby shampoo. Massage the entire scalp gently. Do not get a haircut. The hair will be prepared at the clinic.
Ideally, I would like the donor site area on the patient to have the hair at least 1.5 inches in length or longer. That way, the donor site ellipse is completely concealed from day one.
Preoperative workup. The preoperative workup should include standard laboratory tests with a complete blood count, prothrombin time, and partial thromboplastin time. If indicated, an electrolyte study should be performed, as well as an EKG and cardiac stress test, choosing the donor site. The best donor sites are areas in which hair growth tends to be permanent, primarily the occipital or temporal regions. Ideally, the donor ellipse is taken 3 to 4 centimeters from the upper balding fringe and from the lower hairline boundary in the lower occipital or temporal region. In patients 40 years and older, the safest donor site for ensuring long-term hair growth is located at half of the vertical distance from the posterior upper healthy fringe to the lower hairline. An ellipse removed from this area will compensate for further recession of the donor area. In patients younger than 35, the surgeon can harvest the donor ellipse at the junction of the middle third with the caudal third of the vertical distance from the posterior upper healthy fringe to the lower hairline. In these individuals, the posterior upper fringe tends to recede downward more rapidly than the lower hairline recedes upward from the nape of the neck. The reverse process tends to occur after the age of 60 or 65. That is, the hair also recedes upwards from the nape of the neck.
We have learned that the scalp and the hair does not look thin until you have lost more than 50% of the hair in a given area. With that in mind, you can take up to easily and safely 25% of the available donor hair in the donor area without giving any evidence of thinning in that site. That may vary from patient to patient, but that means several procedures, at least 2 or 3 procedures of sessions can be done safely without having any evidence of thinning in the donor area.
In cases of moderately severe male pattern baldness, 12.5% of the scalp is usually safely available for hair transplantation. That is the equivalent of 12,500 hairs, or 6,250 follicular unit grafts, with an average of 2 hairs each. This means approximately 3,000 to 4,000 micrografts and mini-grafts can be transplanted in 2 megasessions. Designing the new hairline. The design and position of the front hairline is critical for a natural result. Because of the variety of head dimensions and craniofacial proportions, there is no magic number when planning the distance of the new hairline to the eyebrows. However, generally a distance of approximately 8 centimeters from a horizontal line above the eyebrows to the hairline at the midline works well for the mature hairline. For some patients, a slightly longer or shorter distance is appropriate, depending on the shape and size of the head and the proportion of the facial features and skull. A distance of 1 to 2 millimeters must be maintained between grafts during a given session, but once the scalp has healed and the hair begins to grow, the gaps can be grafted so that the desired density is ultimately obtained. Usually patients 45 years and older are pleased with the results of a single megasession, but the density can be increased later if desired. Young patients, especially those under 30, are more demanding as far as density is concerned, and additional procedures should be planned in advance, provided they have sufficient donor areas. A more conservative approach should be adopted in these cases. When designing the new hairline, be conservative. Design a mature hairline with a reasonable degree of frontotemporal recession, even in young patients, that will provide a good aesthetic result in both the short term and long term. Make sure to provide a definite irregularity at the front to mimic a natural result. The appearance of fullness is associated with hair mass, which in turn is related to the number of hairs, the thickness of the individual hair shafts, the texture and color of the hair, and the curliness of the hair. In addition, the contrast of colors between the scalp and the hair also significantly influences the illusion of fullness. Most experts agree that the average healthy non-balding patient has a density of about 200 hairs per centimeter squared, a range of 130 to 280 hairs, and that only 50% of this number is needed to give an appearance of normal density, which is ideally about 100 hairs per centimeter squared, a range of 65 to 140 hairs. Generally, even about 70 to 80 hairs per centimeter squared looks reasonably dense. This number of hairs can realistically be transplanted in 2 sessions of follicular unit micrografting and mini-grafting. Frontotemporal recessions should be incorporated into the plan for mature hairlines. Emphasis is placed on the front hairline instead of on the crown, especially if the donor site is limited. If the ratio of donor to recipient areas is favorable, the surgeon may transplant the entire area of baldness. If the ratio is not favorable, he or she may choose to only transplant the front hairline or a median forelock. If there is insufficient donor hair, the surgeon may choose not to proceed with transplantation. Supplies and equipment. The following supplies and equipment are needed for a typical micrograft and mini-graft megasession. 3.5 times loop magnification for each member of the team, plus 1 or 2 surgical microscopes. A powered surgical table with a narrow removable headrest, such as those made by Midmark, Ritter, or DMI. Foot switch counter. 3 comfortable sitting stools with armrests, such as dental chairs or those made by Stryker. A cool, intense light source. A background light source and 2 sterile disposable transparent sheets. 1 basic pack converters, disposable set of drapes, 1 pack of 4 blue cloth surgical field towels, 1 or 2 packs of dry laps, and approximately 100 4x4-inch gauze pads. A spray bottle containing 2/3 normal saline solution and 1/3 hydrogen peroxide. Hair clippers. A metallic comb with teeth spaced approximately 2 mm apart. Approximately 30 number 11 Persona feather blades. Beaver number 65 mini blades. Number 22.5 sharp point blades. 4 sets of fine surgical jeweler's forceps or accurate scientific and surgical instruments ASSI non-locking needle holders. 1 basic surgical soft tissue set with standard or preferably round surgical blade handles. Mayo scissors. Small hemostats. Towel clips. Brown Adson forceps. 2 double hooks. A bowl of normal saline solution and a 200 milliliter cup for the tumescent solution. 3 autoclave hardwood boards. The following equipment and supplies will also be needed for the procedure: oxygen tank and nasal cannula, oxygen saturation, blood pressure and EKG monitors, 1000 milliliter IV bag containing lactated ringer solution, normal saline solution, or 5% dextrose with 1/2 normal saline solution, IV tubing, and a number 20 gel co-catheter. Midazolam 10 milligrams, Sublimase 50 milligrams. A spray bottle containing 50 milliliters of 0.5% bupivacaine with 1 to 200,000 epinephrine. 150 milliliters of 0.5% lidocaine with 1 to 200,000 epinephrine for tumescence. Cephalosporin 1 gram or alternative. IV antibiotics such as ciprofloxacin 400 milligrams for patients allergic to cephalosporin. Hibiclen solution for skin preparation. 1 bottle of normal saline solution. Surgical marking pen. 8 to 10 pairs of sterile gloves. 3 petri dishes with underlying frozen petri dish holders. 6 round standard surgical blade handles for number 10 and number 11 blades. Approximately 30 number 10 Bard Parker blades. A diptych, 2 Kerlix and 1 3-inch elastic bandage. Technique. Donor site preparation. Conservatively mark the proposed new hairline, allowing the patient to view the markings in a mirror for feedback. Prepare the donor area by marking any lips in the occipital region that can often extend to the temporal region. It should be 1 cm wide and can be 20 to 30 cm in length, depending on the number of grafts needed. Use tape to hold back the longer hairs on the margins of the planned resection and trim only the hair on the donor ellipse. Operating room setup. The surgical team consists of 3 surgical assistants and the surgeon. The patient is placed in the supine position.
Hair transplantation, as presented here, with the use of follicular unit grafts in large numbers, requires a very efficient surgical team. So select assistants that have experience in the use of magnification, they have good hand-to-eye coordination, that can work well together, and stick to the same assistants every time. That's the only way they will get good and efficient.
Anesthesia. The patient is mildly sedated with midazolam, Versed, 2 to 10 milligrams, and fentanyl, Sublimase, 50 to 100 micrograms, which are both titrated for each patient. The patient's vital signs, EKG, and oxygen saturation are monitored throughout the procedure. Supraorbital and occipital nerve blocks are established with 0.5% bupivacaine with 1 to 200,000 epinephrine, approximately 30 milliliters. This includes a ring block just below the proposed hairline. Donor site harvesting. The subcutaneous area is infiltrated with approximately 30 milliliters of tumescent solution, 0.5% lidocaine with 1 to 200,000 epinephrine. This facilitates harvesting by increasing hemostasis, separating the hair follicles from each other and the underlying fascia. In addition, the scalp becomes somewhat stiffer, which facilitates the dissection of the graft. With the patient's head turned to the left, the surgeon harvests the right half of the donor ellipse using the number 10 sharp point blade. The incision must be made parallel to hair follicles when harvesting the donor ellipse. Using double hooks, the surgeon undermines from a cephalic to a caudal direction, making sure to stay at a level just deep to the hair follicle and superficial to any significant vessels or nerves. Generally, there is not much need for undermining unless the strip removed is wider than 1 centimeter. Next, the surgeon undermines from a caudal to a cephalic direction and begins lifting strips off of the donor scalp. In an effort to make quicker progress, the surgeon will remove and suture the right half first, so assistants can start making grafts as the surgeon harvests and sutures the left half of the donor ellipse. The surgeon sutures the donor site with 3-O-proline in a single layer closure without tension. It is important to make sure hair is kept away from and outside of the closure. After closure, the donor site is cleansed with a spray consisting of 1/4 hydrogen peroxide and 3/4 normal saline solution. Graft dissection. Under 3.5 loop magnification, a Persona prep blade is used to slice the donor ellipse into 2 mm thick slices. The cuts must be made in a parallel fashion to preserve the integrity of the grafts. The grafts are cut on a sterile wooden board that provides a non-skid firm surface. While the surgeon closes the donor defect, the assistants begin dissecting and preparing grafts for insertion. The grafts are dissected under magnification with background lighting. 1, 2, 3, and 4 hair follicular unit grafts are individually dissected. The grafts must be cut one by one, making sure to leave a little bit of subcutaneous fatty tissue around the hair shaft. The incisions must be made precisely parallel to the hair shafts to minimize the loss of hair follicles. Take care to make sure that the grafts are not too bulky, have adequate subcutaneous tissue, and have intact bulbs. The grafts are handled gently and atraumatically with jeweler's forceps by the fatty tissue under the hair bulbs or by the tissue around them, not by the hair bulb or dermal hair papilla themselves. The harvested scalp and all grafts are kept chilled in normal saline until transplanted. Once the grafts are ready, they are lined up on a wet blue or green towel. Here, an assistant lines up the grafts in rows of 10 by 10 grafts. These 10 by 10 rows help the team keep count of the grafts. Here a group of 500 follicular micro and mini grafts, 1, 2, 3, and 4 hair grafts, is seen on the blue towel. The following key points should be remembered when the donor site is harvested. Intact follicular units should be maintained whenever feasible. In patients with dark hair, 3.5 times loop magnification is sufficient to dissect most grafts. In patients with light or gray hair, surgical microscopes and background lighting may be needed to accurately dissect grafts. Graft insertion. Area preparation. A tumescent solution of lidocaine and epinephrine is injected intradermally into the graft area, starting at the middle 1/3 and moving toward the posterior 1/3 to achieve optimal hemostasis and to take advantage of the peak effects of epinephrine. Infiltration of the tumescent solution is important for several reasons, the most important of which are to promote hemostasis and to produce temporary edema of the scalp, which facilitate graft insertion. The amount of lidocaine that can be used safely varies, depending on the patient's body mass. In men larger than 75 to 80 kilograms, 150 milliliters of 0.5% lidocaine with 1 to 200,000 epinephrine may be used when transplanting 1,000 grafts or more. If good hemostasis is not obtained with this amount solution, the epinephrine strength is increased to 1 to 100,000. As fibrinogen turns into fibrin, the grafts adhere better to the recipient slits. We repeatedly return to insert more grafts anteriorly, placing them densely to minimize the risk of neighboring grafts popping out. When the surgeon returns to the anterior area to pack the grafts more densely, the epinephrine effect should still be adequate for placing additional grafts. If it is not, more epinephrine is injected. Graft insertion. Starting with the front hairline, slits are made into the area to be grafted, and the graft is inserted with a 22.5 sharp point blade. A stick and place technique is used for inserting the grafts. After the slit for the graft is made, the blade is tilted approximately 10 to 15 degrees to open the entrance of the slit for insertion of the graft. As the graft is inserted, the blade is withdrawn and the tip is used to hold the graft in place. The graft may need to be gently pushed into the slit with the tip of the blade. Care should be taken to ensure that the graft is not injured. More grafts are placed in the periauricular area. Grafts should not be placed too close together because the graft will pop out. Grafting continues on the left side of the scalp to give the fibrinogen on the right side time to turn into fibrin, which will help the graft stay in place. A 22.5 sharp point blade is used to place micrografts at the hairline. When away from the hairline, a feather 11 blade can be used. This blade is larger, which makes grafting easier. The surgeon parts the hair, finds gaps, and places grafts within them. The surgeon works at the vertex of the head to fill in the thinness and cover the patient's large forehead. Next, a second pass is made to add more grafts and fill in little gaps to increase the hair's density. Then the area is allowed to rest so that the fibrinogen can turn into fibrin and more grafts can be added. The grafts should be placed as closely together as possible in a given section to provide reasonable density. In this case, there are about 25 grafts per square centimeter. Graft insertion in other facial areas. Although the procedure for inserting grafts on the face is similar to that for inserting grafts on the scalp, the technique is more difficult because there is a greater tendency for grafts to pop out as others are inserted. When restoring hair to the eyebrows, mustache, or beard, it is best to make most or all of the slits initially in a preliminary fashion and insert the grafts later to minimize the incidence of the grafts popping out. For small cases, the grafts are harvested from a small donor ellipse in the occipital area that is posterior to the mastoid prominence. These grafts are dissected in a fashion similar to that used for dissecting hair follicles for scalp transplantation. The donor ellipse will vary in size, depending on the number of grafts needed and the density of the hair in the donor site. The slits on the face are made with a number 22.5 sharp point blade. However, a number 18 gauge needle can also be used. The blade should always be inserted at the angle of the desired direction of hair growth. When placing grafts in the eyebrow region, the blade should be inserted laterally and upward, following the direction of the natural eyebrows. When transplanting the sideburns or temporal hairline and mustache or beard area, the blade should be angled so that it is oriented with the hair growth. For retroauricular area alopecia, the 22.5 sharp point blade can be used to place follicular micro and mini grafts. After the procedure is complete, dressings are necessary to protect the grafted area for the first 2 days after surgery. 2 layers of 3 by 8 inch adaptic, 2 rolls of Kerlix, and a 3-inch elastic bandage are used to dress the transplant area. The patient is given postoperative instructions, which include the following directives. Rest for the first 72 hours following surgery, while keeping the head elevated at a 45-degree angle. From the first day postoperatively, it is important to ambulate, initially with assistance. Swelling of the eyelids and forehead region will occur on the 2nd or 3rd postoperative day. Swelling is from the normal saline solution and local anesthetic injected into the scalp, and usually resolves by the 7th postoperative day. Cold compresses can be applied to the affected areas. The dressing is removed on the 2nd postoperative day. Wash hair daily with a mild shampoo in lukewarm or room temperature water. Avoid hot water. Make sure that the shower head is set on low pressure or use a cup. After the dressing is removed, wear a cap or hat for protection, especially when going out. Begin applying 5% minoxidil twice daily for 2 to 6 months to help speed the growth of the newly transplanted hair. This may minimize the initial thinning of hair in the grafted areas. If scalp irritation occurs, stop using minoxidil for a few days and switch to 2% minoxidil. If irritation persists, discontinue use. Avoid driving until eyelid swelling has resolved, smoking and strenuous exercise or sports for the first 2 weeks, sun or excessive heat exposure for at least 3 weeks. The stitches in the donor area will be removed 7 to 10 days after surgery. The small crusts that form around the micrograft will fall off naturally 10 days after surgery, along with some of the transplanted hair. However, the hair roots have become safely incorporated into the scalp by this time and are not at risk. Although hair growth will become noticeable 90 to 120 days after surgery, the final result will be evident after 1 year. Problems and complications. Problems and complications specific to hair grafting include dysesthesia and hyposthesia cephalid to the horizontal donor site closure. This usually resolves within a few weeks to a few months. Keloid scars at the donor site. Minor dehiscence at the donor site closure. Ingrown hairs and small inclusion cysts, which can be prevented by leaving the epidermis of the grafts slightly superficial to the epidermis of the recipient's scalp. This technique also prevents small diameter pitting. Results. The micrograft and mini-graft hair transplantation technique provides superior results compared with other hair restoration techniques. This procedure provides natural results, short-term and long-term. Minimal scarring, usually undetectable. Minimal downtime. The transplant can often be accomplished in just 1 or 2 sessions. Furthermore, the direction of the hair can usually be controlled by angling the surgical blade. The desired hairline design can be controlled with precision. The procedure is safe. There are no concerns about flap ischemia, tip necrosis, or expander exposures and extrusion. This 37-year-old man presented with type 3 male pattern baldness. The patient is seen 1 year after 2,450 grafts were transplanted in 2 sessions. This 53-year-old man presented with type 6 male pattern baldness. The patient is seen 1 year after 2,040 follicular unit grafts were transplanted in a single session. Notice the significant rejuvenation and overall aesthetic improvement. This 63-year-old man presented with type 6 male pattern baldness. The patient is seen 2 years after receiving 2,400 grafts in 1 session. This 49-year-old man presented with type 7 male pattern baldness. The patient is seen 1 year after 2,400 follicular unit grafts were transplanted in a single session.